Bismillahirrahmanirrahim. Today we are going to discuss a very important disease of the esophagus, that is dysphagia and its management. Dysphagia means difficulty in swallowing. There is another term which is very much similar to dysphagia, is odynophagia. Odynophagia means painful swallowing. First, etiology of dysphagia. The etiology of dysphagia may be classified into pre-esophageal causes and esophageal causes. First, pre-esophageal causes. The oral phase. In oral phase, the patient may have disturbance in mastication, for example, due to trismus, fracture of the mandible, tumors of the maxilla or mandible, disorders of the temporomandibular joint. The patient may have disturbance in lubrication, for example, due to xerostomia due to radiotherapy and Mikulic's disease. Similarly, the patient may have disturbance in mobility of the tongue due to paralysis, ulcer formation, tumors, inflammatory lesions, for example, glossitis, and total glossectomy. Then defects of the palate may also contribute to dysphagia, for example, cleft palate, oroantral or oronasal fistula. Similarly, lesions of the oral cavity and floor of mouth may also contribute to dysphagia, for example, stomatitis, ulcer formation, tumors, and Ludwig's angina. After oral phase, the patient may have certain etiologies in the pharyngeal phase as well, which may cause dysphagia. For example, obstructive lesions of the pharynx due to kissing tonsils, tumors of the tonsils, tumors of the pharynx, tumors of the base of the tongue, and tumors of the supraglottic larynx. All these, they will cause obstruction in the pharynx. Similarly, some inflammatory lesions of the oral of the pharyngeal pharynx may also lead to dysphagia. For example, acute tonsillitis, acute pharyngitis, quinsy, parapharyngeal abscess, retropharyngeal abscess, and acute epiglottitis. Certain spasmodic conditions, for example, tetanus and rabies, may also contribute to dysphagia. Some paralytic lesions due to cardiovascular accidents, diphtheria, paralysis of the larynx, all they may contribute to dysphagia. After the pre-esophageal causes, the second important causes lie in the esophagus. So these can be further classified into the causes within the lumen of the esophagus, causes which lie in the wall of the esophagus, and the causes which lie outside the wall of the esophagus. First, we take up the causes which are present in the lumen of the esophagus. The lumen of the esophagus may be compromised due to atresia, foreign body, stricture formation, and certain benign or malignant tumors of the esophagus. Second, the causes which are present in the wall of the esophagus. These may be inflammatory, for example, acute and chronic esophagitis. Then motility disorders, for example, increased motility, as for example, due to cricopharyngeal spasm or diffuse esophageal spasm, and sometimes decreased motility of the esophageal wall due to ecclesia cardia and scleroderma may also contribute to dysphagia. Then outside the wall, the causes which are present in the outside the wall of the esophagus, they also cause dysphagia. For example, pharyngeal pouch, hiatus hernia, cervical osteophytes, goiter, and mediastinal lesions, for example, tumors, lymphadenopathy, aneurysm of aorta, and cardiomegaly. And sometimes the vascular rings may also contribute to dysphagia. This vascular ring is because dysphagia due to vascular ring is known as dysphagia lusoria. Clinical features of dysphagia. First, symptoms. The patient with dysphagia will present with dysphagia to solids, liquids, or both. The examiner should ask about the duration of the dysphagia as well. Similarly, the patient may present with regurgitation of food. He may have heartburn. He may have regurgitation of undigested food while lying down and a history of cough at night. This may be due to pharyngeal pouch. Similarly, the patient may give history of aspiration into the larynx, aspiration into the nose. Signs on clinical examination. First, general physical examination, which may show pallor, chylonychia, cachexia, and neck lymph node enlargement. Then systemic examination, especially examination of the oral cavity, examination of the oropharynx, examination of the hypopharynx, examination of the larynx, examination of the neck for lymph nodes, thyroid and larynx, examination of the chest, examination of the central nervous system, especially the cranial nerves. All should be examined in details. Then there are certain investigations which are needed to reach the cause of the dysphagia. For example, blood complete examination, which may include hemoglobin, TLC, DLC, and ESR. Then blood for peripheral film, which will show you the red blood cell morphology. The urine complete examination may show albumin sugar. Similarly, blood urea, blood sugar, serum creatinine, and total serum iron protein. Total serum iron is also done to know the serum iron level. See, total serum iron level in males is 14 to 32 micromoles per liter, whereas in females it is 10 to 28 micromoles per liter. Then iron binding capacity is also inquired. Normally 45 to 70 micromoles per liter is the total is the iron binding capacity. Serum electrolytes and thyroid function test, for example, T3, T4, TSH, and thyroid scan is also done in these patients having dysphagia. Then radiology. Radiology plays a vital role to reach the diagnosis. The different types of X-rays which are taken in a patient having dysphagia are plain X-rays of the soft tissues of the neck, lateral view, X-ray chest, PA, and lateral views, X-rays of cervical spine, AP, and lateral views, X-ray barium swallow, AP, and right oblique views, and video fluoroscopy. Similarly, CT scan from base of the skull to the upper abdomen, and MRI from base of the skull to the upper abdomen. These two, CT scan and MRI, will show you the tumors at gastroesophageal junction. They will help to know the exact site, extent of the lesion, and to pick up the mediastinal mass. The endoscopy and biopsy. This is very, very vital to know the type of the lesion. It may be flexible esophagoscopy, it may be rigid esophagoscopy, and sometimes chromoscopy may be performed. In chromoscopy, we perform the endoscopic examination of the GIT after painting the GIT with dyes. The different types of dyes which can be used are Lugol's iodine, methylene blue, and toluene blue. If we examine The endoscopic examination of the GIT is done after painting the GIT with glucose iodine. Then the normal epithelium will stain brown, whereas injured and metaplastic cells, they take up decreased strain due to decreased glycogen content. And if there is ectopic mucosa, ulcers, or carcinoma and severe dysplasia, all they will remain unstained. So glucose iodine is very vital to stain the GIT. And after glucose iodine painting, we can examine the GIT endoscopically. Similarly, manometric and pH studies may be performed, and ECG is done for fitness of the patient. Treatment of dysphagia. Number one, as the most majority of the patients with dysphagia, they have caxic look and they are very much weak. Therefore, build the patient with different sorts of measures. For example, the patient may be built up with IV fluids, parenteral nutrition, and sometimes the patient may need blood transfusions as well. Then investigate the cause and treat it. For example, if inflammatory lesion is there, antibiotics are used. If the patient is having benign stricture, then dilate the stricture with Bougies or resection of the stricture and then end-to-end anastomosis. If the patient presents with carcinoma of the esophagus, then resection of the tumor and end-to-end anastomosis, if possible, is performed. And if not possible, then radiotherapy is offered to treat the lesion. Now we discuss the esophagoscopy, which is a very important diagnostic tool in dysphagia. What is esophagoscopy? Esophagoscopy is the examination of the esophagus with the help of an instrument known as esophagoscope. Types of esophagoscopy. Number one is the rigid esophagoscopy. Second is the flexible fiber optic esophagoscopy. The third type is the transnasal esophagoscopy. What is rigid esophagoscopy? Rigid esophagoscopy means endoscopic examination of the esophagus with the help of a rigid esophagoscope. Advantages of this rigid esophagoscope. It is more commonly used in therapeutic indications, especially for removal of the foreign bodies. Second advantage is that better visualization of the proximal one-third of the esophagus is in case of rigid esophagoscopy. But there are certain disadvantages as well. For example, general anesthesia is required. It is more costly for the patient because the patient has to be admitted in the ward. The patient's stay will be increased in the hospital. There are more morbidity for the patient. There are more complications such as trauma to different structures and perforation of the esophagus. Concomitant examination of the stomach and intestine is not possible with rigid esophagoscopy. And rigid esophagoscopy is not possible in the presence of trismus and cervical spine degenerative diseases. So these are the certain disadvantages of rigid esophagoscopy. Then fiber optic flexible esophagoscopy. There are certain advantages and there are certain disadvantages in this case as well. The advantages are this flexible fiber optic esophagoscopy is an outdoor procedure. No general anesthesia is required, just local anesthesia with or without IV sedation. There is less morbidity. It can be done in abnormalities of cervical spine and jaw. Stomach and duodenum can be visualized if needed. There is good illumination and magnification in case of flexible fiber optic esophagoscopy. An accurate diagnosis of the mucosal disease may be done with the help of this instrument. But there are certain disadvantages as well. For example, because this instrument is having narrow channel, this will limit the size of the instrument and removal of certain foreign bodies, which cannot be removed with this instrument. Foreign body cannot be retracted into the esophagoscope like rigid esophagoscope. That's why there are more chances of injuring the esophagus. Similarly, hypopharynx and proximal one-third of the esophagus are less distensible with insufflation, so these areas may not be examined adequately. So these are the disadvantages. Now you can see in this figure that this is the flexible fiber optic esophagoscope. These are the different parts. This is the CCD camera. This is the eyepiece through which the surgeon looks into the esophagus. This is the insertion tube, which is inserted through the oral cavity going towards the esophagus, and then the surgeon may introduce this insertion tube into the stomach as well. Technique of flexible fiber optic esophagoscope. First of all, examine the nose of the patient to choose the wider nasal cavity. The scope is passed along the floor of the nose. Then ipsilateral piriform fossa or sinus is observed. After observing this piriform sinus, the scope is further advanced into the esophagus. Then insufflation of the esophagus is performed, and then further scope is advanced into the stomach. Then scope is retroflexed to see the complete view of gastroesophageal junction, and then slowly withdraw the fiber optic esophagoscope. And while withdrawing, you again examine the esophagus carefully. This is the whole technique of the fiber optic flexible esophagoscopy. This is the transnasal esophagoscope. You can see the patient is sitting on a chair, and the examiner again first examines the nasal cavities, and he will introduce the insertion. This tube is inserted through the wider nasal cavity along the floor, and he will go further down to examine the piriform fossa, then the esophagoscope. So this is the transnasal esophagoscope. For transnasal esophagoscopy, you can perform this procedure using topical anesthesia. For the nose, you spray 4% lidocaine. The position is seated position facing the examiner, as you have seen in the photograph. Rigid esophagoscopy is very important tool to examine the esophagus for certain indications, which may be diagnostic indications or they may be therapeutic indications. The diagnostic indications are: number one, to find out the cause of the dysphagia. For example, carcinoma of the esophagus, ecclesia cardia, stricture, and esophagitis. Second, to find out the cause of retrosternal burning. For example, due to reflux esophagitis, hiatus hernia. to know the cause of hematemesis, for example, esophageal varices. Number 4, secondary lymph node in the neck with unknown priming as a part of pan endoscopy. Then there are certain therapeutic indications in which we perform the rigid esophagoscopy. For example, to remove foreign body from the esophagus, dilatation of the stricture, dilatation of the cardiac atlasia, removal of some benign tumor, for example, fibroma, papilloma from the esophagus. Similarly, we can inject some sclerosing agent into the esophageal varices, and we can insert Mosio Marlin tube in palliative treatment of carcinoma of the esophagus. These are the therapeutic indications. Contraindications. There are certain contraindications for rigid esophagoscopy. For example, trismus, diseases of the cervical spine such as Cary's spine, cervical spondylosis, kyphosis, aneurysm of aorta, advanced heart disease, and advanced renal failure. Anesthesia. The rigid esophagoscopy is always performed under general anesthesia. The technique is, first of all, protection of the lips and teeth. Then lubrication of the scope is performed with liquid paraffin. Then holding of the scope. Then identification of the laryngopharynx structures. Then advancement further into the cricopharyngeal sphincter, crossing the arch of aorta and left bronchus, and then passing the cardia and followed by withdrawal. And when we withdraw the rigid esophagoscope, we then again carefully examine the esophagus for any lesion or some other disease present in the esophagus. Now this figure is showing you the technique of insertion of the rigid esophagoscope while the patient is under general anesthesia. Post-operative care. The patient is advised, number 1, nothing paroral. He should be given intravenous fluids. He should maintain the vital signs. Then note the signs of esophageal perforation. If signs of perforation are present, then treat the patient as patient of esophageal perforation. If no such signs are there, start sips of water first and then usual diet after a few hours. Complications of rigid esophagoscopy. During rigid esophagoscopy, the surgeon may cause injury to different structures. For example, injury to the lips, teeth, gums, arytenoids, pharynx, ulceration of the esophagus, perforation of the esophagus, which is most important complication. And he may compress the trachea as well. Similarly, sometimes dislocation of the temporomandibular joint may occur during performing the rigid esophagoscopy. Then the important topic is perforation of the esophagus. Perforation of the esophagus is mostly iatrogenic when rigid esophagoscopy is performed. So, etiology of the perforation of the esophagus is trauma in the form of instrumental trauma to the esophagus. That is called the iatrogenic perforation of the esophagus. It may occur due to rigid esophagoscopy while performing dilatation of the stricture. It may occur sometimes trauma due to road traffic accidents. It may occur due to penetrating injuries of the neck or chest. Sometimes gunshot injuries of the neck or chest may cause perforation of the esophagus. Second, malignant tumors of the esophagus may cause perforation of the esophagus. Similarly, there may occur spontaneous rupture of the lower one-third of the esophagus in Boerhaave syndrome. This Boerhaave syndrome is a triad of post-emetic perforation of the esophagus, distension of the stomach, and both pleural cavities contain fluid smelling a roast duck. Macular's triad, which includes chest pain, vomiting, and subcutaneous emphysema, is a classical presentation but present in only 14% of the people with Boerhaave syndrome. Macular's triad. Management. Management of the perforation of the esophagus includes history, physical examination, investigations, and treatment. First of all, history. History of some etiological factor, for example, gunshot injury or esophagoscopy, is inquired. Then pain in the interscapular region, then fever. Examination of the patient includes vital signs monitoring, raised temperature monitoring, surgical emphysema within 1 hour of perforation, tenderness at the site, and examination of the chest. Investigations include X-rays, neck, lateral view. It will show you gas shadow in the prevertebral area. Then X-ray chest PA view, which may show you wide mediastinum, surgical emphysema, pneumothorax, pleural effusion, or gas under the diaphragm. CT scan of the neck and chest may also be advised in case of perforation of the esophagus in certain cases. Treatment. It depends upon site of the perforation and duration of the perforation. First, perforation of the cervical part of the esophagus. If diagnosed within 24 hours of its occurrence, then conservative treatment is advised. It will consist of nothing peroral till further orders, monitor the vital signs, IV fluids are started, pass the nasogastric tube for continuous nasoesophageal suction, and parenteral antibiotics in the form of triple regime. For example, ampicillin or third generation cephalosporin, for example, ceftriaxone, secondly, gentamicin or some other aminoglycoside to cover the gram-negative microorganisms, and thirdly, flagyl to cover the anaerobes. In most of the cases, the perforation will close within a week or so spontaneously by this conservative treatment, provided the patient of cervical esophagus perforation presents within first 24 hours. If the patient reports late, for example, or if he is diagnosed later than 24 hours, then the infection will be established, and so the patient will be treated. Number one, with conservative treatment, which I have already narrated, plus surgical drainage of the neck and mediastinum by neck and chest intubation, and perforation, not sutured in this case, rather it will close spontaneously. So this is the treatment in those cases of cervical esophageal perforation if the patient presents later than 24 hours. Then perforation of the thoracic part of the esophagus. It depends upon type of perforation and duration of perforation. If perforation is non-malignant and it is diagnosed within 2 hours, then active conservative treatment in the form of nothing peroral till further orders, monitor the vital signs, IV fluids, continuous nasoesophageal suction for at least 7 to 10 days, and parenteral antibiotics, as already mentioned, they will almost cause closure of the perforation. If perforation of thoracic part with stricture is diagnosed after 2 hours, but within 24 hours, then surgical treatment in the form of thoracotomy, repair of the perforation, resection of the stricture and end-to-end anastomosis of the esophagus, and active conservative treatment. If diagnosed beyond 24 hours, contamination of the mediastinum will be there, and so very poor prognosis, that is death of the patient, is the result in this case. Now this X-rays is showing you left pleural effusion with shifting of the mediastinum towards the right side. This is the air fluid level. This is the left lung which has been collapsed, and this is the fluid in the pleural cavity. Left pleural effusion which has pushed the mediastinum towards the right side. This is the shadow of the esophagus. This is the X-rays showing you the air in the mediastinum. Mediastinum. Air shadow is seen there with increasing width of the mediastinum. This is mediastinum widening. It is more width than the normal one. Mediastinal widening is defined as a mediastinum with a measured width greater than 8 cm on the chest X-rays. Mediastinum to chest width ratio is greater than 0.25. This is indicating the greater width of the mediastinum on this X-rays. This is the X-ray showing you this is the X-ray of the chest and abdomen showing you the air under diaphragm. This is the air under diaphragm showing you some sort of perforation of the viscera. Again, this is the X-ray of the chest and abdomen, again showing you the free air under diaphragm. This is again indicating that some sort of perforation is there. The third important topic to be discussed is the corrosive burn of the esophagus. This corrosive burn of the esophagus is a serious medical emergency with a variety of clinical presentations and a complicated clinical course. Usually, the corrosive intake is taken as a suicidal or homicidal attempt, but sometimes it may be accidental happening. There are certain differences between alkalis and acids. For example, pH is more than 7 in alkalis and it is less than 7 in acids. Amount that can be ingested is larger in case of alkalis, as these are tasteless and odorless. As the acids are pungent and they taste noxiously, therefore the intake of acids is lesser as compared to the alkalis. Depth of injury. Depth of injury is deeper due to liquefactive necrosis and direct extension, whereas depth of injury is in acids is limited due to formation of a coagulant layer, because acids they cause coagulation necrosis. Associated gastric injury is more commonly seen in case of alkalis, whereas it is less common in case of acids. It is normally said that the acids they lick the esophagus and bite the pyloric antrum, whereas the opposite situation results from alkaline ingestion. Etiology. First, the acids. Acids intake, the patient can take alkalis or some other chemicals. If the patient takes acids, the acids will cause coagulation of the part affected, so damage is limited. The acids are present in toilet bowl cleaners, for example, sulfuric acid, hydrochloric acid. Then acids may be seen in anti-rust compounds, for example, hydrochloric acid, oxalic acid, hydrofluoric acid. Similarly, swimming pool cleaners may also contain hydrofluoric acid. Then alkalis. Alkalis cause liquefactive necrosis, so the damage will be more as compared to acids. Examples of alkalis are cleaning agents drain openers, bleaching agents, and battery cells containing alkalis. These battery cells are very notorious, especially in children. The children, while playing with battery cells, they may ingest them. And similarly, other chemicals may also cause corrosive intake. Damage or pathology which is caused by the due to acid intake, it depends upon type of the corrosive, amount of corrosive, duration of contact with the esophageal wall, pH of the solution. It has been seen that the damage is greatest if the pH is more than 12. Then physical form of the corrosive, whether it is a solid corrosive or it's a liquid one. Endoscopic classification, that is called the Zerger's classification of corrosive intake. It can be classified into different grades from starting from 0 to 4. Grade 0 is when there is no damage to the esophageal mucosa. The esophageal mucosa remains normal. Then grade 1, superficial mucosal edema and erythema. Grade 2. Grade 2 means mucosal and submucosal ulceration. It can be subdivided into 2A and 2B. 2A means superficial ulceration, erosion, and exudate. 2B means deep, discrete, or circumferential ulcer formation. Grade 3 is transmural ulceration with necrosis. It can be further subdivided into 3A and 3B. 3A includes focal necrosis, whereas 3B includes extensive necrosis of the esophagus. The fourth one, grade fourth one, denotes perforation of the esophageal wall. This is the Zerger's classification, that is the endoscopic classification of esophageal injury due to corrosive intake. Clinical features. Airway obstruction. The airway obstruction may occur in corrosive intake due to edema of the epiglottis, edema of the larynx, edema of the tongue, edema of the oral cavity. Then pain in the oral cavity, odynophagia, oral cavity ulceration, edema of the lip, tongue, cheeks, epiglottis, and larynx, and increased salivation. Pain in the neck, chest, and abdomen. The patient may have vomiting and hematemesis as well sometimes. The patient may present in shock-like condition. Therefore, in a case of corrosive intake, always monitor the patient for signs of airway obstruction. If the patient presents with airway obstruction, then do not lose time. First, perform tracheostomy to save the life of the patient, because endotracheal intubation is very difficult in these cases due to edema of the oral cavity and larynx. So tracheostomy is very important step to save the life of the patient if the patient of corrosive intake presents with signs and symptoms of respiratory obstruction. Investigations. Routine investigations, arterial blood gases, which may show you acidosis or alkalosis, then serum electrolytes, blood for grouping and cross matching, renal function test, X-ray soft tissue neck lateral view, X-ray chest PI view to rule out perforation of the esophagus, and X-ray abdomen to rule out perforation of the bowel as well. Ultrasonography abdomen and pelvis, endoscopic ultrasound, CT scan of the chest and abdomen, barium swallow examinations, and endoscopy. Complications. The early complications which may occur due to corrosive intake are respiratory distress or obstruction, odynophagia, perforation of the esophagus, tracheoesophageal fistula, mediastinitis, pleural effusion, infection, septicemia, shock, and death sometimes. Late complications may be the stricture formation. In those having grade 2B or grade 3 injury or more, these patients will have stricture formation. Peak incidence is seen after 2 months of corrosive intake. As early as 2 weeks or as late as years after Corrosive ingestion, you may see stricture formation. Barium swallow X-rays are helpful in evaluation. The patient may have dysphagia due to stricture formation. Then the patient may also develop carcinoma in the strictures area in rare cases. Only 5% after 20 to 25 years after the Corrosive intake, the patient may develop carcinoma in the stricture area. Management. Management includes early management, late management, and follow-up of the patient. First, early management. Early management includes pre-hospital care, emergency department care, consultations, and medications. Pre-hospital care. Dilution using water or milk may be beneficial if the patient has corrosive intake within 30 minutes to remove any adherent particles to the oral or esophageal mucosa. Do not induce emesis in case of corrosive intake because it may cause aspiration or perforation of the esophagus if it is so too forceful. Do not use sodium bicarbonate because it will produce carbon dioxide which may increase the risk of esophageal perforation. Then emergency department care. Care of the ABC, airway, then breathing and circulation of the patient, very, very important because for this purpose, there should be airway control equipment for endotracheal intubation or cricothyrotomy or sometimes tracheostomy should be ready available because the patient may present with respiratory distress in case of corrosive intake. Second, gastric emptying and decontamination by using NG tube and make the patient NPO. Then certain laboratory investigations are asked for example, CBC, blood grouping and cross matching, pH of the saliva, serum electrolytes, renal function tests, and urine analysis. Then consultations. Psychiatric consultation for all those patients having history of intentional ingestion of corrosive should be asked for. Similarly, surgical consultation is also required if there is evidence of perforation of the esophagus, such as severe back pain or retrosternal pain, evidence of peritonitis, free air under diaphragm or in the peritoneum or mediastinum, and evidence of extravasation of contrast material while performing the barium swallow X-ray. Then endoscopic consultation is required in small children, symptomatic older children, and patients having altered mental status. Then medications. Corticosteroids, for example, dexamethasone, 1 milligram per kg per day IV in divided dose, but its role is controversial. The corticosteroids are used to minimize the chances of formation of the stricture in the esophagus after corrosive intake. Secondly, collagen synthesis inhibitors such as penicillamine and N-acetylcysteine may also be prescribed. Antibiotics, broad spectrum, preferably triple regime is started. H2 receptor blocker, for example, cimetidine or proton pump inhibitor, omeprazole, are also prescribed. Parenteral nutrition is essential as well in these cases when enteral feeding cannot be maintained by usual means. So this is, thank you so much.